gastroenterology and hepatology in practical, you should understand there are many study which I take all my lecture from this one. You can take all these lectures and this from my lectures. So it is a huge work which I did in the last 2 weeks. But remember that this disease is a new infectious disease. It's a global understanding. Global understanding continuously deep and involving, according to survey to 2,000 physicians in China, the rate of awareness or collect knowledge about this disease-induced damage of gastroenterology, it's about 30%. So all the people remember about it is pulmonary, not digestive disease, and they make a survey that 30% of the doctors, they don't know about that. It may manifest by pneumonia, but can cause digestive system damage to the digestive organs. Clinical issue which we try to speak about that is there is any fecal oral transmissions, management of gastrointestinal symptoms, adverse reaction of therapeutic drugs, nutritional support, IBD and pandemics, infection control. So there is a fecal oral transmission route or not. As you see that in mild disease there is digestive disease, marked digestive symptoms, as it may be positive for RNA in the stools. Diarrhea can be the initial presentations of COVID-19, maybe only later or never present with respiratory system. So your patients can come only with diarrhea. Experience delayed diagnosis compared to the patient with only respiratory system. So he found that there is some delayed diagnosis. It may reflect a higher viral load in these patients compared to those with only respiratory systems. This data emphasizes patients with new onset of digestive system after a possible COVID-19 contact should be suspected for illness, even in the absence of cough, shortness of breath, sore throat, or fever. So if you have a patient with a new digestive symptoms, with a possible contact, has no symptoms of respiratory, so you should suspect the illness. So PCR testings on the feces, especially presenting the digestive systems. Why it occurs? Because digestive systems contain angiotensin converting enzymes, 2, and this reported both present in the upper and lower GIT and expressed as 100% higher than in the respiratory organ. So angiotensin converting enzymes, which is, as Professor Schiff said, is a target for the virus, present 100% in the GIT. And viral acid is detected ovary in the feces in over than half of the patients infected with COVID-19. 1/4 of the cases sample positive when the respiratory sample are negative. So this is indicated that something is important. This is angiotensin converting molecule target for COVID-19, and you see that it's present in the lung. It attacks lung in 100%, heart in 20%, but 40%, liver in 40%, kidney in 20%. So this is an involvement because all of these containing angiotensin converting enzymes. Attention should be paid to the fecal contaminations, either by contact or aerosol transmissions, which is especially during colonoscopy. Protection from fecal should be provided to the medical staff. What we do to the medical staff, you should have a knowledge, all of you, which are sharing in this one, you should understand this very important. You should have a knowledge, should improve the triage and the consultant process, which is very important. Pay attention to the screening of potential COVID-19 patients. Medical manifestations of digestive systems, as you see, patient can get by diarrhea, by loss of appetite, by vomiting, loss of smell, abnormal liver function. So all these manifestations can be present. If you look for the incidence, appetite about 50%, diarrhea about 50%, nausea 30%, vomiting 15%, abdominal pain 6%. In some cases, severe gastrointestinal bleeding in about 4%. COVID-19 is diagnosed or suspected. It's always distinction. You should take care that some of the drug used for treatment of COVID-19 can cause diarrhea also. So you should understanding of this condition. So if you get diarrhea, it may be due to a drug used for treatment. Nutrition support. Many patients need nutrition assessment, very important because they cannot eat. So they carry parenteral nutrition, but in the long run, you should encourage for oral nutrition, oral eating, encourage very quickly, and should start it when it can be possible. This is very important. IBD, it's a special conditions in this epidemic or pandemics. There's no data reported in the instance of COVID infections in IBD patients until now. However, patients with IBD, particularly with an immunosuppressive agent or biological, might be immunocompromised, should follow all the relevant guidelines to minimize exposure to this virus. During the active phase of the IBD, patient may show symptoms such as fever and diarrhea, and this may overlap with symptoms of COVID infection of the virus. So patients with IBD may have a symptom in acute phase like the symptoms of the virus. So patient awareness is very important. IBD patients on steroid immunosuppression or biological strongly recommended. Unnecessary travel, mass gathering should be avoided. Patient of IBD, immunosuppression agent or biological might be immunocompromised, as we said. Until March 23, as Professor Schiff read this paper every one day, there are about 3,000 papers now on this virus, many of them, or half of them, on gastroenterology and liver disease. There are 40 cases of IBD reported globally. According to the data, now the data called the Therapians Epidemiology of Coronavirus under Research Exclusion, the Cure IBD Registry, and now with 2 deaths. During active phase of IBD, maybe show symptoms as fever and diarrhea as it overlap. Particularly important with patients will inform the knowledge. You should have the knowledge and self-management during the pandemic because of this special category of patients. What is the management strategy? Patient with active IBD or in remission, safety of medications, deal with IBD patient infected with the virus. Physician or nurses should also consider the access of health care for IBD patients during this special pandemic prevention period and provide adequate patient education through different platforms, telephone, online situation, social media, the knowledge of IBD or prevention of the virus. So this is very important. If you have a patient with IBD, you should, because they're afraid now about, because immune compromise, they're afraid of infection of the virus. Now, how to recognize your IBD unit for regular visits in cases of social restriction. For these patients or on regular monitoring, virtual clinics or online should be advised. And please take care to schedule at the same time of the scheduled visits in your clinics. Endoscopic procedure should be limited to patients suffering from moderate to severe. Regular endoscopic follow-up and screening should be postponed. Strict hygiene conditions for endoscopic procedure must be implemented. There are many randomized controlled trials now. So this randomized home delivery of the study drugs administered orally or subcutaneously to the patients in the randomized with many application forms they can apply and send it online because they cannot stop the randomized controlled trial. In case of any urgency in IBD, what you can do, and this is also very important. Close contact with the referral IBD centers. It's important to give the right indication at the right time, including when to come to the hospital. Sometimes the patient is living far away from you, so at the referral center. So your team can ask another team in a nearer center to take care of this patient for hospitalization. So if you have patient has an urgent and they call you from, say, from Alexandria, from Tanta, from everywhere, send to him to another nearer center, he can go there and he can be, the same concept can be applied for the case of IBD flaring or complications. So this is how to deal with the patient of IBD in this time of social distance. In a symptomatic patient with stable disease more than 1 year, shall we delay or postpone infusion visit to limit contact with the hospital? If yes, what type? For this, with normal calprotectin or other biomarkers, we can postpone infliximab to every 10 weeks, and also vidofludimus can postpone to 4 to 8 weeks. This is the intravenous use to postpone to prevent to come to the hospital. If any possibility to switch from IVV biological to subcutaneous injections, yes, you can switch subcutaneous drugs to be limited in the center when infusions are not more available. A different approach can be considered for those who start a new biological. In this case, you should start by subcutaneous drugs. We prefer not to come to the hospital. So this is the shift of the biological. This is yes. Patients under immunosuppression mediated treatment therapy has received instruction to stay isolated from home for suspected V. What you do? If the patient is infected, what you do? First things, this patient IBD and infected. You should stop cytopenia, like Imuran, in case of suspected infection, may be responsible. The benefit and the harmful should be carefully weighted before using corticosteroids. The mechanism of action of methotrexate should not increase the risk of severe course, but postpone injections. Biological should be postponed until resolution of infection. Temporary. Stopping immunosuppressions therapy should not have any effect of risk of IBD flaring. So this is what we can use at that time. In patient with active IBD, and the IBD medicine which you should avoid to initiate this point. If IBD flare, we should promptly treat it to avoid hospitalization and the complication needed surgery. This means what? If you have an IBD flare, you should treat it very carefully to prevent hospitalization. All drug indicated for treating of IBD flare can be used in this stage. Added cyprin to steroid or to monoclonal antibody should be used very cautiously because it reduces CD4 T cells and delayed virus screening. This means that if you have an IBD patient and they have a flare, you should promote the treatment very, very hardly. This is to prevent to come to the hospital, to prevent the complications. And you should not add many drugs, try only one drugs. Should we use biological medicine in elderly patients? Speak about elderly patients with other patient with comorbidity. Shall be different from other patients? We should continue to treat IBD patients similar to how we were in the pre-COVID-19 world. For elderly patients, try the best you can use monotherapy to limit the use of immunomodulator, to use monotherapy. Keeping elderly patient out of flare. This is very important with immunosuppression or immunomodulator if needed. So if needed, keep this patient out of flare because if they get flare, they will be hospitalized. Potentially decrease their risk of contracting. Why? Because by using that, you prevent decreasing the risk of getting virus infection and prevent our patient from having to go to the hospital with risk of infection is amplified. As I know, this cure, which is resulted from collective data, as I said to you, it's 41 patients are collected at that time with 2 mortality. One is 82 years male from Europe with Alzheimer's disease, cardiovascular, and used only saline. And another one was 25 years male with ulcerative colitis, moderately active disease, and used infliximab with methotrexate. This is the 2 cases died reported until now. This is healthcare professional. What's mean by that? There are many of the people working in the healthcare are IBD, either doctor or nurse, but he works it. So it's rare that IBD patients are involved in the healthcare system. It's not rare. It's prefer to avoid a flare during this time. So avoid to flare at this time. If you are a nurse or a doctor, have an IBD, should try not to flare at that time. So treatment should be modified preemptively if anyone at work. Recommendation of personal protective equipment, which is PPE, for vulnerable cases. Don't differ from any other worker. Local association have recommended that these people should redeployment, which is he can go to other places, to the clinical area and duty, have reduced exposure to patient and confirm suspected cases. So this is something related to IBD, but IBD doctors and IBD nurses. If you're not IBD, you should prevent flaring of your disease. You should have a protective way of measurement to protect yourself, and they can change your place from one to another place. If you speak again, what is the system about endoscopy? This is a nice word which I said it before, that COVID-19 pandemic through the lens of gastroenterology, looking for the silver lining. What's mean by the silver lining? Any situations, hopeful side of situation may be seen globally surface. Every crude has a silver lining, meaning that even the worst event situation have some positive effect. So we still have some positive. So we can still ensure our success in becoming well-trained gastroenterology by working together solution to the new problem, being innovative and always looking for the silver lining. So silver linings mean that you still are something good in that area. Challenging area in a medical staff, for this medical staff, it affects personal life, it affects professional life, work environment, education, finance. It's a time when we can still present a united front in fighting of a pandemic, while simultaneously maintaining a moral. There is a clear and urgent plan for endoscopy over the coming week and months. It's very difficult, this is challenging time to decide what is the best for the patient, population, authorities, or health worker, because situation is markedly changing. And so what I said like before, we try to make guidance. We will not like to make a guideline, but to make guidance from all the paper which we have. You try to restrict your number of staff in the room. If you are doing endoscopy, try to restrict. Limited advanced endoscopy to small number of specialty consultant. No training is now. If you have a problem, the most specific one in this area should work. Consider alternative for diagnostic tests like calprotectin for IBD, radiology, telephone triage, or something like that. Decision on making endoscopy. In these decisions, I will try to work very quickly. So something need to continue, something which you stop, and something which you need discussions. Need to continue is bleeding, esophageal obstruction, cholangitis, perforations, symptomatic pancreatic biliary disease, patient with time-sensitive diagnosis, evaluation of pre-malignant or malignant conditions, urgent inpatients nutrition support, evaluation of GIT obstruction, case where endoscopic procedure with urgent change management. Like in IBD, I said, it can be only in a severe cases and you like to change the management. What you should not do, all routine symptomatic referral, planned poems, pneumatic dilatations, elective surgery, bariatric endoscopy, low risk esophagitis healing, gastric healing, poor view, check, POTS therapy, amplectomy, all that should be stopped. Surveillance of polyp, IBD, Barrett, routine non-urgent small bowel, OUS for benign lesions, other ERCP, if you have a stone with no reached cholangitis and the stent in place, do nothing, therapy of chronic pancreatitis, metal stent removal, patient undergoing endoscopy biopsy for part of the clinical trial, no. Motility slide, no. Screening with surround colonoscopy in asymptomatic patient, screening upper GIT in asymptomatic patients, in evaluation delayed for 4 to 6 weeks. This is something which is not related to my lecture, but this is related to the virus now. Please, all of you, avoid sending fatalistic messages. Some people don't have the same mental strength as you. Instead of helping them, you could active pathology such as depression. So not to try to send the message about this disease. Upper GI should be regarded as erythrolytic prone procedure, AGP. Should be remembered that provide mask and person protective. Neither all expected should be as a case where an N95 mask equivalent. Classifications of potential risk. So you have a low risk, intermediate risk, and high risk. What's the low risk? It is no symptoms, no contact with someone, no stay in high risk area. This is a low risk. Intermediate risk, presence of symptoms, or presence of symptoms, but no medical history of contact with person, no stay in high risk area, no symptom, but contact with someone who's positive, stay in a high risk area. High risk, at least one symptom and one of the following. Contact with someone which is positive, stay in high risk area. So this is a 3 risk. So if you're low risk, you suggest a surgical mask, you suggest hairnet, Google, and single-use gloves. Single-use gown also, and then gloves. You have an intermediate risk, upper GI endoscopy considered as a high risk. So you go here. Lower endoscopy considered as low risk procedure, it go here. High risk, you should have an N suspected of N95 or FFB, respiratory, hairnet, goggle on the face, long sleeve water resistance gown, minimal 2 pairs of gloves. 2 pairs of gloves you should use. And this is the difference between A and B, low risk and high risk. So if you go to this area, this is an A risk, which is single-use gown here, and hairnet, and Google, and surgical mask, and the glove. If you go to the B, which is high risk, now the gown is long sleeve water resistance gown, Google, hairnet, and N95 or FFB2 respiratory with 2 pairs of gloves over the gown. So this is simply, but I try to make it simply, how if you do endoscopy, what you do, first step, put your hairnet, second, hand hygiene, third one, put your gown, fifth steps, put your N95, but recommended fitting test. It's very important to be done after putting on the face. Fifth steps, put your goggle. Sixth, put one glove. So the inner one, 2. So one inner pair of the glove covering the skin up to the wrist, and the second one glove over the gown up to the wrist. So you have 2 them. But here, what is the most important, try to make it simply again. First test, net, second hygiene, third gown, and then fifth putting it in the 5, fifth one goggle, sixth one 2 gloves. And this is the pictures of totally, and this is when I do an endoscopy like ERCP goggle. Goggle, hairnet, and N95, and this is very important, and water resistance gown. And this is 2 gloves one over the gown and one over the skin. He said to take it easy, but most important in how to remove it, because the most dangerous area is to remove it. First step, hygiene of your hand with the gown. Then remove your gloves. After you remove your gloves, you make a third step, hand hygiene. And then you put one glove again after putting hand hygiene. And then the fifth one, you remove your gown, then you remove your goggle, then you remove your mask, then you remove your hairnet. Ninth thing, you remove your gloves which are used again, and then make an hand hygiene. So this is a way how to remove the personal protective equipment. And it's very important because you can be infected when you remove it. You can take care when you're wearing it, but when you remove it, you can be infected. And this is the steps very quickly. A simple tricks also during endoscopy that use suctions during removal of the biopsy forceps. And by this time, because this is the most dangerous type, when you make a biopsy and you remove the biopsy forceps, many gush is coming. So make suction with a simple trick. You can use it when you remove your forceps. This is outside of my lectures, but I think it's important also. After the lecture, if possible, listen to music at home, a pleasant volume, look to games to the children's, tell a story, and look for a future. You should have a future and should plan for your futures. Liver injury, yes, it's very important. Limit our patient visit to only patient who must be seen in person and the patient with urgent issue. Follow a recommendation for person protection. If person protection is not available, keep distance at least 6 feet from the patient. Patient arrival to avoid patient, take patient by patient, appropriate distance between them, strongly consider phone visit or telemedicine if possible. Rising of hepatic infection during liver disease because of chronic hypoxia. Most of the COVID-19 related viruses which are mild and only need close without intervention. Liver injury is mild cases, usually transient, does not require specific treatment. The mortality of liver transplant recipient with this virus may be significantly higher than of populations. The incidence of injury of liver, it's about 30 to about 40%. And there are rare cases of acute hepatitis which describe with patients with this virus. Low serum albumin on the hospital admission is a marker of COVID-19 severity. Take care of antiviral drugs which used to treat this virus are hepatotoxic. So take care all of that. That if you have, so for the liver, you should dealing with the liver disease in a manner that online or something like that. Also remember that when you treat patients with drugs for this virus, that may be hepatotoxics. Relation between unknown patients with chronic liver disease, especially with hepatitis B and C, may be more susceptible to liver damage because that happened with SARS-CoV-1. It's very important. For COVID infection, exacerbation cholestasis in those patients with underlying cholestatic liver disease, such as primary biliary cirrhosis or primary sclerosing cholangitis. So it can exacerbate cholestasis in these patients. It may be at increased risk in patients with alpha anti-1 antitrypsin deficiency with lung disease, and the patient with NAFL may be at higher risk of severe COVID-19. So this is the relation between liver and COVID-19. Recommendation of treatment of disease. Continue treatment of virus B and C. Continue. Proceed with treatment of hepatitis B and C in patients without the virus, without infections. Initiate treatment of virus B in a patient with COVID-19 is not routine, but should be considered if there is a clinical suspicion of hepatitis B flaring when initiating immunosuppressive therapy. Initiating treatment of hepatitis C in patients with this virus is not routinely important, so don't treat at that time. Continue monitoring cases of hepatocellular carcinoma. Continuous surveillance at risk, the patient at risk. to be scheduled allow delay of 2 months is reasonable to delay the screening. Consider virtual visit, discuss diagnosis and management of hepatocellular carcinoma. Proceed with hepatocellular treatment when able rather than delayed due to this pandemic. So this is some about hepatocellular carcinoma and this virus. Patient with compensated liver transplant evaluation. Ensure that patients have refill available of essential medicine for 90 days supply instead of 30 days. This means some patients take the drugs, say from the government or from anyone, so give him essential medication for at least 3 months, not 1 month. So give him the drugs, this is your drugs for 3 months. Advise patient not to travel during that time. Have a low ratio of admitted patient on the transplant waiting list. So patient at transplant wait don't admit it for that reason. Consider specific screening facility and for this one, for this virus-free busway through the hospital transplant candidate. Conduct patient transplant educations. Patient make them education, social work, financial consultation by video conference, telemedicine, or telephone whenever possible. Avoid multiple patients in one room during patient educations. Mission of immunosuppression. In immunosuppressed liver disease, patient without any virus don't make any things adjustment. But in immunocompromised, in immunosuppressed liver disease, patient with the virus, consider minimize dose of the high dose of prednisolone, but maintain a sufficient dose to avoid adrenal insufficiency. So this is if I have a patient of liver transplant who is using or immunosuppressive drugs. Consider reducing azoxystrobin or myclophenolate dose, especially in setting of lymphopenia, because of the fever or worse pneumonia attributed to COVID-19. So first thing, decrease the dose of prednisone. Second thing, reducing azoxystrobin or myclophenolate. Consider reducing but not stopping daily calcineurin inhibitor dose, especially in setting of lymphopenia and the fever, because or worsening pulmonary state attributed to virus. So this is how to use during this time of liver disease, how to manipulate with the drugs which are using to this immunosuppressed patients, either transplanted or using the drugs because of autoimmune liver disease. Initiate immunosuppressive therapy in patients with liver disease with or without who have strong indication for treatment, autoimmune hepatitis or graft rejections. Start the treatment. With or without, minimize in-person visit for post-transplantation by maximum using telemedicine. So maximize continuous visits of patient of transplant to your clinics or to your hospitals, but making it by telemedicine. And take care of these patients have many drugs. So take care of drug-drug interaction if they get infected. What I said at the end, stay safe, but also stay positive. Stay positive and learn in your future. Look for this one. What I cannot control, I cannot control how this pandemic will last. I cannot control who will get ill and who cannot not. I cannot control who will survive. I cannot control what's the stock. I cannot control other people's reactions. So I cannot control all these, but what I can control, I can control my attitude, who I contact with, my exposure to negativity, what I can grateful for, my routine, how I take care of myself, how I spend my time, what I do for fun, my reaction. So we can control many things. Don't look for this blue area. You cannot control anything, but you control this one and then you survive. Try to plan your future plan. Don't stop. That means everything is finished. And I still planning for my Congress. It may be not happen at all, but I still focus and continue future planning because this is what I can control. I cannot control all these things, which is in blue. And thank you very much. And thank you for the company, and Dr. Sharif. Thank you, Mahmoud, and thank you, Value, for that.